Bismillahirrahmanirrahim. Allahumma salli ala Sayyidina wa Maulana Muhammad wa ala alihi wa sahbihi wa barik wa sallim. Thank you PSIM for inviting me for this talk today, which is a very important talk, Advancing Treatment Strategies in Diabetes Management. I'm not going to talk about any new modality of treatment. I'm just going to talk about new strategies which can lead to a better diabetes management in our country. I don't have anything to disclose. This is my humble introduction. I'm a student of medicine, working as a professor of medicine in a private medical school and a visiting consultant at different hospitals at Lahore. Those who know me, I usually start my talk with some lesson, some message. So being a poet, Urdu poet, हमेशा उर्दू शायरी से कोई मैसेज देके शुरू करता हूँ ताकि ऑडियंस जाग जाए. So the message for today is, कोई गम से परेशान है, कोई जन्नत का तालिब है, गरज सजदे कराती है, इबादत कौन करता है? Isn't it? हम लोग जब नमाज पढ़ते हैं या कोई भी इबादत करते हैं, उसके बाद एक लंबी एप्लीकेशन अल्लाह ताला को देते हैं, 1 2 3 4 5 6 7 8 9 10. तो बेगरज इबादत अल्लाह ताला की जो शख्स करता है, डेफिनेटली वो ज़्यादा मकबूल है. बेगरज इबादत चट्टानें भी करती है. You can see this rock having sajda in front of Allah. So my learning objectives for today is I'm going to talk about diabetes and HbA1c. We know that HbA1c is the key parameter in diabetes control for the last almost 35 years. But now we are moving on. We are moving on for a change, which is time in range now. And we have got something called derived time in range. I'm just going to talk about these two things. Then definitely I'm going to talk about IDEC aspart, which is a combination of ultra-long insulin, which is insulin degludec, and an ultra-short-acting insulin, insulin aspart, some evidence-based medicine, and summary and takeaways. So diabetes management is definitely a tightrope to walk on. Whenever you are treating diabetes, even though the sugar level is well controlled, you will face hypoglycemias and hyperglycemia. It's mandatory in diabetes management. So our purpose is to have a diabetes management in which we have less hypos and less hyper. So the concept of time in range came recently into picture, and I'm going to talk about it in detail. What are the unmet needs in the diabetes management? Every need is unmet. Unfortunately, we have to have improved adherence for the drugs. The disease burden is increasing. Unfortunately, we have been named as the capital of diabetes, as you know, and the increasing prevalence is 26 to 30% according to the IDF data lately. Glycemic control is not still. We have to have a better glycemic control to prevent complications and glycemic variations. We have got CGM, continuous glucose monitoring. So many new technologies are coming up. This is an era of, I call it chip era. You have got chip for everything. And tomorrow the humans will be machines, unfortunately. History of glycemic control using different parameters. The history started from 1966 when HbA1c came into picture, and still HbA1c is still the gold standard of diabetes management. But we know that HbA1c has got some limitations. It cannot control, it cannot predict about hypoglycemias, hyperglycemias. So the concept of continuous glucose monitoring came into picture in 1999, and this is going on still, and now it has been labeled as time in range concept. HbA1c era, what we had, it's still the main glycemic metric. It's still the main metric for the quality of diabetes care. It's still the main diagnostic criteria. Standard marker to assess complications, targeted standards, and different regulatory authorities, they still recommend HbA1c to be the top parameter in diabetes control. This is the latest ADA guidelines, and if you see this carefully, one word is being repeated throughout the guidelines. In every column you will see if HbA1c. If HbA1c is above target, if HbA1c. So HbA1c is still the gold standard. I'm not denying the need of HbA1c, but I'm going beyond HbA1c right now. So what are the limitations of HbA1c? HbA1c alone cannot guide improvement in glycemic targets. HbA1c does not identify hypoglycemia and glucose excursions. HbA1c can be affected with a wide variety of physiological and pathological conditions, which we are going to talk about in the coming slide. And HbA1c can be associated with a wide range of glucose profile. The sugar level will be up, down, but the average HbA1c will remain the same. I'm going to give you an example in the coming slide. So HbA1c can be affected with a wide range of physiological and pathological conditions: anemia, thalassemia, blood disorders, aging, pregnancy, many drugs. So many things can affect. Some can increase HbA1c, some can decrease HbA1c. So these physiological and pathological conditions will give you a falsely high or a falsely low HbA1c, which will not give us a good parameter. And now I told you already that HbA1c can be associated with a wide range of glucose levels. Just imagine we have got 3 examples in which HbA1c is the same. It's 7, 7, 7. In the first example, if you see, 58% we have got the sugar level which was more than 180 milligram per deciliter, 18% was between 70 to 80, and 24% we had hypos. But the average is 7. It's a bit opposite. Major control was there in the second example. We had hyperglycemias and less hypoglycemia. The HbA1c was 7. And in the third example, it's all controlled. Everything is within the control, and HbA1c is 7. So in all these 3 examples, HbA1c remains the 7, but glucose excursion and hypoglycemias are seen. So it's time to move on. We have to move on. Change is definitely for good, if it is for good, by the way. Some changes are not for good. So time in range concept can capture variations, hypoglycemias, hyperglycemias, and definitely we have to have time in range, which is the normal glucose levels. What is continuous glucose monitoring? Continuous glucose monitoring is of 2 types. We have real-time continuous glucose monitoring, and we have intermittent continuous glucose monitoring, or flash glucose monitoring. Real-time glucose monitoring, you have to apply a machine with you which is going to record everything in the 24 hours. Every second sugar level will be recorded, and at the end it will give you a graph which will tell you the sugar levels are going hypo, hyper, or in the range. In intermittent, you have to apply a sensor. The Libre is the most common example of this, and you have to scan this and you have to find different readings. Continuous glucose monitoring has got some benefits. Benefits is that you can have excursions, daily profiles, variability, hypo and hyper, but definitely this is not readily available. The sensor might take some time. There might be some delay in recording. So definitely there are limitations in continuous glucose monitoring. What is the definition of time in range? That this is the range at time a patient is within the glycemic range of 70 to 180 milligrams per deciliter. And according to the major guidelines, it should be more than 70% of the blood glucose level of all the patients in majority of guidelines. So time in range is inversely correlated to the complications. It is an important endpoint, and it can record hyperglycemia and hypoglycemia much more specifically. I'm sorry I have to be a bit fast because time is running away. So what should be the target time in range? Generally, in patients with type 1 diabetes mellitus and type 2 diabetes mellitus, the target range should be more than 70%. This is our target. If you're talking about hypos, it should be not more than 4%, and severe hypoglycemia should not be more than 1%. Hyperglycemia between 180 and 250 should not be more than 25%, and 5% can be more than 250. So this is an ideal sugar control in a patient with type 1 and type 2 diabetes mellitus. If you are talking about high-risk patients who are prone to have hypoglycemia, then we are a bit generous. The time in range should be more than 50%, as compared to this one, more than 70%. In pregnancy, the target range changes. The upper limit is 140 milligram per deciliter. In type 1 diabetics, we should have more than 70%. And in gestational diabetes, who are diagnosed during this pregnancy, or the patients who are having type 2 diabetes beforehand, we are a bit cautious, and the control should be more than 90%. But we don't have data for gestational diabetes and type 2 diabetes mellitus, so we have not included the percentage. Each 5% increase in time in range is associated with significant benefits in patients with pregnancy and type 1 diabetes mellitus. So time in range and microvascular complications, these are inversely proportional. If time in range will increase, the microvascular complications will decrease. For each 10% less time in range, you will have retinopathy increase in 64%. It's a big number. And microalbuminuria will increase by 40%. A brief comparison of HbA1c and time in range. It's a single value. It compares every 3 months. Variability, hypos, hyper will not be recorded. Immediate effects will be missed. And susceptibility with different physiological and pathological conditions. But the good thing, it is still the main important clinical endpoint in all the guidelines. HbA1c is still recommended. If you talk about time in range, it's a continuous glucose monitoring. It can be recorded anytime. Glucose excursions can be recorded. Immediate effects can be recorded, not affected by any diseases. But unfortunately, it's not readily available. The data is much less for this time in range. Time in range is always related to HbA1c. I'm not talking against HbA1c, very frankly speaking. It's always related to HbA1c, and the target is 70%. You can see the HbA1c will be 6.7. Now, very briefly, I'm going to touch this ultra-long-acting insulin, insulin degludec, with a combination of aspart and its effect on time in range. Something called derived time in range. I call it desi time in range. Everybody does not have CGM. So you can calculate this time in range by a simple method. In this study, what they did, they got 9 points SMBG recordings at week 0, 12, 16, and 26. What are the 9 points? 3 times before meals, 3 times 90 minutes after meals, 1 at bedtime, 1 at early morning, dawn time, and 1 was the next breakfast. So these 9 readings were calculated, and number of in-range fingerstick readings divided by total number of recordings multiplied by 100. Very simple formula, and this will give you a time in range clearly, which is called derived time in range. Insulin degludec in this study, which compared insulin degludec with insulin glargine, U100 and also U300, they found the half-life. Everybody knows that the half-life is much more than that, and that's a flat glucose control with insulin degludec, which persists for 24 hours. This is the same slide in which we see that if you give glargine, there is a crest and then there is a trough, but insulin degludec will maintain as compared to U100 or U300 insulin glargine. This is a Japanese study, which is the latest study. I just downloaded last night. It compared 2 studies, and they calculated the derived time in range, and they found that idaglera, which is a combination of degludec with aspart, was associated with significant increase in derived time in range with basal insulin combination. I'll just take 1 more minute. 5 steps. There are 5 steps to calculate, to interpret ambulatory glucose profile analysis. First is the data. You have to have the data. Number 2, you have to have hypoglycemia assessment. Then you must know what is the time in range for that particular patient. Then you have to know the variabilities, hyperglycemias, and at the end you should know the stability. In this way, very simply, you can predict the ambulatory glucose monitoring, and you tell exactly what is going on with the patient. Very briefly, a case, 61 years old male, type 2 diabetic. He was on oral anti-diabetic drugs and insulin, glargine, a good dose of insulin. HbA1c was not controlled. He went to his doctor. What he did, he stopped sulfonylurea, definitely. He modified his oral medications, and he switched to this patient to idaglera. And a follow-up was taken after 4 months, and you can see that his sugar level is more or less in the time in range. The graph clearly shows that the major component of diabetes control is within the range. Idaglera offers a flexible regime. You know, if you're taking it BD and you have to travel, for example, you have got a flight at 5 p.m., what to do? You're taking this drug at 6 p.m. So of course you're not going to take it in the plane. So what will you do? Take it at 5 p.m. It's not a big deal. Take it early. Take it with the big meal. It's not going to cause hypoglycemia. Number 2, we need to sleep on Sundays. They kept us awake because of this lecture today. So if you want to sleep on Sunday at 11 a.m., just wake up at 11 a.m. So warning shot is coming up. Take home message is that now time to change from HbA1c to time in range. Idaglera has got better capability and flexible regime. The center I was trained, I was asked to put a slide and keep quiet and let the audience enjoy it. For my friends who don't understand Urdu, don't understand Urdu, afiyat, peace. Peace has got 10 components. 9 components is silence, and 1 component is keeping away from the people. You can imagine where are we going these days. Unfortunately, thank you very much for patient listening, because I think listening is learning. Thank you very much.
Thank you.